It's Matthew Holt at the World Healthcare Congress. Just came out of a session I've been moderating, and I've got two of the three people of the session with me. On the left here is Ben Sawyer, who is the Executive Vice President of CareLogistics, which is a technology company wrapped in a consulting company, wrapped in a technology company from Alpharetta, Georgia. On the right, Imran Andrabi, who is the President and CEO of Mercy's Vincent Health Center in Toledo, Ohio. So I'm going to start. We've just been doing this session, which is called Achieving Total Hospital Efficiency Through Care Coordination, Transformation, and Enabling Technologies. That's a big mouthful there. So I'm going to start with you, Imran. What was the problem at your hospital that you were fixing to solve?
Well, I think that the problem that we were trying to fix to solve in our hospital was the same that's wrong with the entire healthcare system. It's fragmented, it doesn't have the patient centered in the middle of it, and it's not efficient. And as you've seen and heard, there's approximately 40 to 45% inefficiencies and waste in the system. And we were trying to take away the white space, the non-value added work, and really create value for the patient at the bedside.
So you did that by essentially putting in what you refer to as an air traffic control system, 6 full-time employees doing care coordination across the entire hospital system, sort of patient input to patient, all the way across the patient experience. Tell me a little bit about what you had to do to achieve that.
Well, it's just to correct you a little bit, it's approximately 100 people that are in the care coordination system that we put across the system.
Right.
And basically what we've been able to achieve is a significantly improved throughput of our patients, which is flow of our patients through the hospital system. We have significantly reduced our length of stay in our hospital on the acute side from 5.2 days to 3.83 days in a hospital, which is a very complex regional referral center, a level 1 trauma center with 8 ICUs and an average CMI of 1.88. That's a significant change for a hospital of that magnitude. We've been able to significantly improve our quality and patient safety, reduce our preventable harm measures by 72.5%, and at the same time improve our patient experience.
Yeah, and you also improved your margin significantly and felt a lot of that.
I didn't talk about that.
You didn't talk about that, but you didn't decide. In fact, the one person who wasn't there was Samantha Platsky, the CFO of the overall system.
We have actually seen a $48 million positive to the bottom line in the last 2 years, and in the last year alone, a $26 million improvement in our bottom line went from a average operating margin of 1.9% to 5.3%.
Right, so a pretty significant change just by some really thorough re-engineering. So let's talk, Ben, about what that means and what sort of CareLogistics brought to the table as part of this. So first off, give people the thumbnail sketch about the system that CareLogistics puts into a customer like Mercy.
Good question. It's a human system and a technical system that goes after exactly what Dr. Andrabi was talking about, which is fragmentation and variability. So the way that evidences itself is inefficiencies with silo-based handoffs and lots of wasted steps. So we initially map the entire flow process with the hospital staff to make sure that there's an understanding of opportunity to wash out white space or waste. And then there is the insertion of this logistical core that Dr. Andrabi was talking about.
So the white space would be something as simple as like a transporter going one place with a patient, then leaving with an empty wheelchair for 5 minutes.
Here's a great example. Bedside nurses during the morning when they're trying to coordinate for a patient might make multiple calls, like a dozen calls, to coordinate diagnostics and services. That's a part of the process that's wasted. And when you can eliminate that, that goes right to reducing patient waits and increasing their access to services, which increases quality. So that's a good example of white space.
So the other thing that you've done as part of the technology core is there's a lot of visual display across the hospital. So talk a little bit about what you guys do in that area, and what you're displaying and how you're displaying it.
So what's interesting with visualization, Matthew, is that visualization by itself is not effective. Using the airport example, if you have stoplights on runways and it's green, who lands, right? So the idea is you're dealing with simultaneous patient throughput, and you're making sure that you have prioritization and queuing so that the right thing happens at the right time. So the technology had to be able to support that from an integrated workflow standpoint, and then in turn provide real-time feedback back to all the stakeholders so they know at any given time where they're at in the process and how they need to respond.
All right. So let's talk a little bit about the cultural impact of that, Imran. As it's your show, you explain to me how that how that worked. Now, as you mentioned inside, a lot of people have heard of management change and reorganization and always sort of said this is going to go away and going to pass. How did you make this one stick to such big results?
I think the big reason, quite frankly, when I look back as to what is the reason why this stuck, two big things. One is it's about the patient, stupid. That's the reason why each and every one who works in the healthcare system came into the healthcare system was to do something right for the patient. And number two is really engaging the people at the front line to come up with the answers and the solutions that need to be then executed to make that care better for the patient. So we had to execute really in engaging the people at the front line, the management staff, the executive staff, and the CEOs, quite frankly, to be a part of the solution and be out there and visible to make the change happen.
And you also, as we discussed in the session, you're changing things on a rapid basis. It's kind of like software prototyping that, the beta that everyone seems to be permanently better. You change a little bit of this, change a bit of that, and see what works and get results back very quickly.
That's true. We, through what we call our quality operating system, we actually now make incremental changes in a 1-week cycle. So in the past, we used to get a report on a patient condition once a quarter, once in 6 months, and then you would look at a report and you would say, well, it's a number. Today, when we go on a floor and we talk about a patient experience issue, or we talk about a quality issue, it's a patient in room so-and-so who's still there, and you talk about why did a particular issue happen, and then you put into effect the solutions that come from the frontline people, and then you go back and take a look at what impact it's had within a 1-week period of time. So this is rapid cycle change management, and people are very engaged in the process, and because they can see the changes that are happening right in front of them and the results that come back to them as a result.
Great. 2 last questions, one for each of you. Ben, first one for you. You did this in a hospital which I would say has not necessarily got the latest and greatest in terms of things like real-time location and some of the new systems we've seen which are coming out in terms of lapel, voice communications, and who knows what else is going on in there. How is the growth of that type of technology in hospitals, whether it's Mercy or any other one, going to impact what you do? And how are you going to cope with that at CareLogistics?
It's a good question, and before I answer that, I want to just add to the context. Mercy St. Vincent's is a safety net hospital. They have a very challenging payer mix, and as a result of that, they have to be selective about what they invest in.
Sure.
So the idea is to be able to leverage it anywhere, and St. Vincent's is a good example of that. Now, the technology of RTLS RFID really expands the capability of being able to do specific location of patients and or assets in the throughput process. Again, this is all about simultaneous patient movement against limited assets. So the quicker and better you know where those assets are, whether they're people, diagnostic equipment, etc., the more efficiently you can manage, and the more options you have for prioritization and queuing in real time.
How much, the follow-up to that, how much room for improvement of what you've already done do you think those types of technologies could help? Or do you think it's mostly human at this stage?
No, I would say, at a macro level, I think most experts say there's probably 40 to 45% waste in the healthcare system, and I don't know what percent Emrod would say that he has been able to wash out with this process because it's an ongoing journey. But let's say, for example, that we've washed out 20 to 25% waste. That means that it gets tougher and tougher to get more efficient, and that's where you want to leverage both human system innovations as well as technical system innovations to just continue to get that white space out of sort of every nook and cranny.
Right. Imran, last question for you. The underlying macro feature of this conference has been the concept of, obviously with just the recent announcement of the move to ACOs and the concept of putting the hospital not just as part of, you talked a lot about coordination of care within the hospital system and, and going through the emergency room and all that, but of course across the whole healthcare system. And how do you think that both your hospital and this type of technology is going to play into this wider issue as we go to a world of ACOs and bundle payments and all that kind of good stuff?
Well, I think it plays right into it because, as you develop efficiencies and you take out the waste from the system, you're now creating a capable system within a hospital to be able to deliver on that promise. So not only do you take a look at the continuum, but you need to have very efficient, capable systems within the continuum of care that can provide on that particular promise. The other thing that we're looking at is really taking some of the learnings that we've had within our hospital and apply it to the entire continuum of care, both in the pre-acute area and the post-acute area, to be ready and able for the bundled payments and the ACO model. So this is a great learning experience for us to have done this in the acute care setting and then be able to take the learnings to the entire continuum of care.
You suspect it's not going to get too much easier, right? Probably not.
Right.
Great. I've been talking with Imran Adravi and Ben Sawyer. Gents, thanks very much, and nice job so far.
Thanks,
Matthew.